So today I will be talking a bit about vaccination around the world, what are some struggles, where are some areas that we can improve. But I thought I could first start off just by introducing my university and where I came from. So this was just a couple of days ago before coming here to Indonesia. It was Friday. It was very cold, very, very cold at my university. This is where I work, and I am very happy to be now in Indonesia, where it is sunny and warm, and my colleagues are all very jealous of me. So I want to start off with a question. How have we made so much progress in deaths from vaccine-preventable diseases? And certainly if you look at the numbers, we've made remarkable improvements in the health of children, particularly children, but also adults worldwide. So there's many fewer people who are getting these vaccine-preventable diseases, many fewer people dying of these vaccine-preventable diseases. So about 30 years ago, there were still about 4 million people each year who died from vaccine-preventable diseases, and now it is fewer than 3 million. But still, that's 2.7 million. That's still millions of children who are dying from these diseases which we can prevent. So why is that still the case? One thing I also think which is interesting to consider is that the decline is not the same across all diseases. So, for instance, measles, we used to have about 500,000 people, 500,000 people would die of measles each year, but now it's really around 100,000. So there's been a big decline. So a lot fewer cases of measles, a lot fewer people dying. But there's still around 1 million children each year who die of pneumonia. Why is that the case? Another question I want to ask before I start trying to answer some of these. Are we living in the platinum age of vaccinology? So I was reading a textbook and they used this phrase, the platinum age of vaccinology, and I found it really, really interesting. So I wanted to bring it up. And I think why people might think this is that we have more vaccines now than ever. We're producing a lot of vaccines. There's new technologies. There's new ways of making vaccines. So the vaccines of nowadays are much different, and maybe they're better than vaccines previously. And the number of vaccines certainly has increased a lot. So just looking in the United States, the number of vaccines which everyone has, nowadays we recommend around 12 vaccines for every child to get. And that is many more than there was even 10, 20, 30 years ago. So when I was a kid, there was really only about 4 different series of vaccines which were recommended for children. And when my parents were kids, there was really only about 3. So, 2 generations ago we had 2 or 3 vaccines. When I was a kid, we had 3 or 4, and now we have 12 vaccines. That's a large number of vaccines. But are we really using these to the full extent that we can be using these? Maybe not. And I think there are 3 different ways where we have been struggling with vaccines worldwide. One is with financing, it's money issues. Let's say we overcome that, we have enough money for vaccines. Are we equitably distributing vaccines? So is everyone getting the vaccine who should be getting vaccines? So that's from a government perspective. Like, is the government able to release vaccines into the population? The third one is maintaining demand. So do people want vaccines? So maybe the government has the vaccines, but does a person, do people, do mothers, fathers, do they want vaccines? So I'll talk a bit about these, and I'll give you a few different examples. So measles. So certainly measles is a success story, like I was telling at the beginning of this session. There's been a remarkable decrease in the number of cases from measles. So the measles vaccine in the United States was introduced in the 60s. So here, and so you can definitely see that when the vaccine was licensed and when it was used, there was a substantial drop in the number of cases from measles. And so really there was about 10, 15 years where we didn't see any measles cases in the United States. But then all of a sudden, around 1990, there was a lot of cases. There was about 3,000 cases. In historical scheme, maybe that doesn't seem like so much. You know, certainly there was a lot of cases back in the 60s, and only about 3,000 in 1990. But still, that seemed like a lot, and that seemed unacceptably too much. So people were thinking, were individuals getting vaccines in the United States? So this is a chart of vaccination coverage, and it's looking at over time how many people are getting vaccinated, and this is the percentage of people who are vaccinated. And what you can see is actually it's declining over time. So for a lot of these vaccines, like for measles, for polio, for diphtheria, tetanus, pertussis, there's declining rates of vaccination. And why is that the case? So one of the things is in the United States we have private insurance, so we have to pay for a lot of our healthcare. And historically that was also for vaccines, so parents would have to pay for their vaccines. So after this huge outbreak of measles in the United States, the government decided to start publicly funding some vaccines. And so they started this program called Vaccines for Children, or VFC. And basically this was a way for the government to pay for vaccines. And to be honest, I think the United States was behind a lot of other countries in this program. I'm guessing that even Indonesia was publicly funding vaccines prior to this date. But it took us until 1994, and it took us until this big measles outbreak to start funding vaccines. So it's a money issue. So maybe the reason why we had so many declines and why there was this decline was that parents just couldn't afford the vaccines. So after the start of this Vaccines for Children program, you can see that a lot of the uptake for different vaccines became really high. So we think maybe this is a success story here in the United States. We developed a program where we were able to publicly fund vaccines, and as a result, more people are getting the vaccines. I think it's interesting looking worldwide what vaccines are recommended. So what vaccines are used in different countries, and maybe there's some money reasons behind that as well. Because the WHO puts together a list of vaccines which they think every country should use. So, you know, this includes things like hepatitis, polio, HIV, pneumococcal, so this prevents pneumonia, rotavirus, which prevents diarrhea, measles, of course. They have some vaccines which they recommend, maybe in some circumstances, in some countries which have enough money, maybe they can be funding these, but these are sort of second-tier vaccines. So, like was said, I do a lot of research in China, and so I think it's interesting to look at like what vaccines are being used in China. And for instance, they're not really using the pneumococcal vaccine, they're not using rotavirus or HIV. And if you compare that to other countries like India and Ethiopia, they do have those vaccines. I believe Indonesia uses a lot of these vaccines, maybe the exception being the pneumococcal vaccine. I'm not sure if that's really being used much here. So some of these vaccines are very expensive, a lot of these new vaccines are expensive. So when we think of the platinum age of vaccinology, we use new technologies, but new things are always expensive. They require a lot of money. So there was this organization which was put together, the Gavi Vaccine Alliance, which funds a lot of vaccines. It funds a lot of vaccination work throughout the world, and it works with governments. And it's had a pretty good track record. They've almost vaccinated about 1 billion children, and they've worked with a lot of countries throughout the world to try to introduce new vaccines. And this is funded a lot through the Bill and Melinda Gates Foundation. So the Gates Foundation is funding this, but of course it has support from the WHO, UNICEF. But Gavi primarily works in low-income countries, and it works less in middle-income countries. And what do I mean by that? So if we think of income distribution throughout the world, of course it's unequal, and some countries are more wealthy than others. We have, well, historically we say developed countries, developing countries. Now in the United States we like to use this terminology of high-income countries and then middle-income countries. And middle-income countries could either be upper middle or lower middle, and then low-income countries. So I looked at the World Bank website to get these numbers. And so, I work a lot in China, which is an upper middle-income country. Indonesia here, you're kind of on the cusp between a lower middle-income country and an upper middle-income country. And I've done some work in India as well, so that's just a comparison. So Gavi, so this vaccine organization, they will support countries sort of in this low-income category and maybe a bit in this lower middle-income category. But as countries become a bit wealthier, so as they become upper middle-income countries, and certainly as they become high-income countries, Gavi won't support vaccines. However, I want to point out that there seems to be a huge difference between the wealth that we have in the United States as a high-income country and the wealth in middle-income countries where maybe you're still being expected to introduce a lot of new vaccines. So this is a paper I worked on with some Chinese colleagues, and we were looking at the price of vaccines in different locations. And the takeaway message is that a lot of these new vaccines are very expensive. So things like the pneumococcal vaccine, in the United States it costs over $100. So that's really expensive. And when you think a child needs 3 doses, maybe 4 doses of this vaccine, that adds up. That's a lot of money. One way you can try to reduce the cost of vaccines is to use what's called a group purchasing organization, or to kind of come together, like a lot of countries to come together.
Dan transporting. Kalau seandainya mereka kan cuma bisa minus, katakan kalau ada sampel yang bagus, kemudian yang mahal, kemudian mereka hanya bisa nyimpan di minus 20. Jadi sebenarnya kita tidak bisa lama kan itu. Jadi ada pengiriman secara reguler ke lab yang memiliki minus 80 kan seperti itu. Jadi saya menggunakan Ekman Institute untuk keeping sampel sebelum ditransport. Dan transportnya juga memakan waktu yang sangat lama. Sebenarnya kalau dikerjakan tidak masalah, tidak perlu harus ada izin dari Kementerian Kesehatan, tapi ada MOU dari rumah sakit, dari institusi kita dengan institusi yang mau dimana dikirim, jelas apa sampelnya mau dibagaimanakan, prosesnya apa, dan setelah selesai sampelnya mau dikemanakan seperti itu. Jadi proses seperti itu. Dan di Western Australia juga travelers itu memang kita ada cohort, jadi semua pasien yang dengue dan segala macam yang demam dari luar negeri itu biasanya kita enroll, kemudian sampelnya kita ambil, kemudian kita simpan. Jadi memang sudah ada sistem seperti itu. Jadi lebih gampang kerja sebenarnya kalau caranya dari sana. Kemudian masalah mengenai 3 pertanyaan sebenarnya itu hanya sebagai satu gambaran bahwa penelitian itu tidak. Tapi sebenarnya itu penelitian yang sudah ada, tapi ketika ada data-data penelitian yang sisa, tapi ketika mendapat penelitian besar, biasanya ada data-data sisa. Itu bisa diolah lagi menggunakan tiga pertanyaan itu. Artinya kita menggunakan variable dependent variable-nya cuma 3 pertanyaan. Dengan 3 pertanyaan itu bisa menjadi satu, kemudian satu itu kemudian kita kaitkan dengan berbagai variable, explanatory variable. Jadi dengan 3 pertanyaan sebenarnya itu bisa kita lakukan. Bahkan misalkan besok pagi, kalau seandainya ada yang cerdik, besok pagi itu ada yang corona, sampel pasien itu ada, bukan sampel, sorry, peserta ada sekitar di atas 80. Kalau seandainya ada orang yang menyiapkan 1 lembar pertanyaan, katakan 1 lembar pertanyaan berisi dari katakanlah seberapa Anda khawatir terhadap ini, data demografis, kemudian pertanyaan seberapa khawatir Anda posisinya apa, misalkan dokter atau perawat segala macam. Dengan menggunakan itu saja sebenarnya, walaupun ini sebenarnya nggak etik, kalau seandainya apa kan harus ada ethical clearance-nya. Kalau seandainya seperti itu saja bisa dipublikasi sebenarnya dengan 80 pasien, dengan 80 peserta di sekitar 2 jam itu bisa menghasilkan sesuatu yang bisa dipublish at least di Q3 atau kalau seandainya bagus bisa di Q2.
Kalau yang misalnya jurnal yang di aseptik itu yang apakah dia melihat jumlah populasinya, misalnya harus 300 itu sampelnya, atau misalnya dengan sampel sekitar di bawah 100 bisa di aseptik kalau di jurnal-jurnal.
Tergantung apakah. Jadi kalau seandainya beberapa jurnal memang diminta ada minimal sample size harus ada dihitung. Tapi sebenarnya tidak harus. Misalkan kalau saya reviewer, saya tidak melihat minimal sample size. Kalau seandainya dikatakan I have calculated sample size